All right. Last on the blood cells are their red blood cells. So let's get started. Your mature red blood cells are called erythrocytes. They're the most common type of blood cell that we have. No nucleus. They're thin and biconcave, and their shape allows them to perform their most important function, which is to transport oxygen. Red blood cells contain hemoglobin, which is what the oxygen binds to. Very important. Hemoglobin, each molecule of hemoglobin carries 4 molecules of oxygen. Iron is what causes the reddish appearance when blood is oxygenated. And then if you think about it, when you draw blood from veins, which is deoxygenated or lacks the oxygen, it's darker and sometimes on that bluish appearance. If you draw blood out of an artery that has oxygen in it, the iron is what gives it its reddish appearance. 2 types of hemoglobin, the adult hemoglobin and then fetal hemoglobin, just for your information there. Iron has to be present for hemoglobin to form. Iron is stored in tissues like the liver as ferritin. Probably remember that from chemistry class maybe, and that is a protein-iron complex. Erythropoiesis is the production of red blood cells. You have to know that. It takes place in the bone marrow. Erythropoiesis, the production of red blood cells, occurs in the bone marrow. Red blood cells begin as baby red blood cells, which are erythroblasts. Blasts are babies. Then they progress to reticulocytes and mature to full erythrocytes, or your red blood cells. Now, something important that I want you to know, and you can highlight this, anytime there is a decrease in oxygen anywhere in the body, your kidneys respond by releasing erythropoietin, which is a hormone, into the blood. That is what stimulates and causes red blood cell production in the bone marrow. Okay? So, think about it. A decrease in oxygen, the body compensates by the kidneys releasing erythropoietin into the blood. Then that stimulates erythropoiesis in the bone marrow. Now, if I ask you on the test, where does erythropoietin come from? It comes from the kidney. Erythropoiesis takes place in the bone marrow. I can guarantee that those 2 questions will be on the test because people always mess up and think that red blood cells are produced in the kidneys or get these 2 confused. So I want you to know that slide very well, please, and that the whole process starts because there's a decrease in oxygen in the body. A red blood cell's lifespan is about 120 days. You want to maintain homeostasis. So the red blood cell production is supposed to equal the red blood cell destruction. Destruction occurs in the liver, spleen, bone marrow, and lymph nodes. The amino acids and iron from those destroyed red blood cells are reused by the body. The rest of that stuff from the red blood cells is converted to bilirubin. Okay? If there is an increase in the amount of bilirubin in somebody because maybe they're destroying too many red blood cells, then the person will become jaundiced, or that nice yellowish gold color. There are 2 different types of bilirubin, conjugated and unconjugated, and it is the unconjugated that builds up in the blood and causes jaundice. But just remember that your body actually reuses certain amino acids and iron from destroyed red blood cells, and the rest is converted to bilirubin and supposed to be broken down in the liver, which is why patients who have liver problems, their livers aren't functioning appropriately, will sometimes become jaundiced. Red blood cells have no mitochondria. So think back to the first day of class, what process does red blood cell metabolism occur if they don't have mitochondria? Just something for you to think about. Now, I want you to know specific lab data for your red blood cell uh, count and then other counts as well. Your red blood cell count equals your total number of red blood cells. And you can find all this information in your book. Red blood cell count for men should be 4.2 to 5.4. In females, you're going to see a little bit of a decrease, 3.6 to 5.0. Your reticulocyte count is basically showing you your rate of red blood cell production. Normally, that's going to be 1 to 1.5% of your total red blood cell count, 1 to 1.5%. Hemoglobin shows you the hemoglobin content in the blood. And remember, it's the hemoglobin that carries the oxygen. It'll be a little bit different in male and females. Men, hemoglobin should be 14 to 16.5. Females is usually around 12 to 15. The hematocrit is the volume of cells in 100 milliliters of blood. Volume of cells, volume of red blood cells in 100 milliliter blood. Again, you see a little bit of difference in men and women. Men is usually about 40 to 50%. Women is usually 37 to 47%. What we usually look at to determine whether or not somebody is anemic is not necessarily their red blood cell count, their total red blood cell count. What we look at is the hemoglobin and the hematocrit. Those are usually the two main values that we look at to determine if somebody is actually anemic or if their blood count is actually low. Some other lab data that help with classifying what type of anemias someone may have. A very important value I would like for you to know is the MCV, or the mean corpuscular volume. Basically, with the MCV, we're looking at the size of the red blood cell. How big is it? Is it normal in size, or is it too small or too large? The normal MCV count should be anywhere from 85 to 100. If it's less than 85, then it's microcytic or small in size. If it's greater than 100, it's macrocytic. Again, if it's anywhere between 85 and 100, then it's normal, and that's the size of the red blood cell. Next lab data that you will see in your complete blood counts are your MCHC, which is the mean corpuscular hemoglobin concentration, which basically just tells the concentration of hemoglobin in an individual cell. And with MCHC, we're looking at the color. MCV was looking at the size. MCHC is looking at the color. Is it normal or normochromic, or does it have a decreased or lighter color? In that case, it would be hypochromic. And again, that kind of gives you some specifics on determining what's causing their anemia. Are they iron deficient? Are they B12 deficient? Are they not deficient in anything? Are they just flat out bleeding? What's the problem? Your normal MCHC is 31 to 35. So let's talk about anemia. Anemia is when you have a low hemoglobin level or a low or decreased amount of red blood cells in the blood. It can be caused by several different things. Number one, maybe you've lost blood for some reason, you're bleeding. Number two, maybe your body is destroying red blood cells for some reason, or hemolysis, however you want to say that. Or three, maybe you're just not producing enough red blood cells. Maybe you have bone marrow failure, a certain type of cancer, or you've taken chemo, or maybe you're B12 deficient or iron deficient. So your body's not producing enough red blood cells. No matter what's causing your anemia, the decrease in hemoglobin is going to cause you to have a decrease in oxygen, or hypoxia, if you remember that from the first class. And it can cause you to have certain signs and symptoms. You're going to be tired and weak, short of breath or dyspneic, angina. You're going to have probably some chest pain from the lack of blood flow through the heart. You may have a headache. You're probably going pale, which is pallor, and your heart rate may increase with tachycardia. So let's talk about the first cause of anemia, flat out bleeding or blood loss. Basically, you've lost enough iron-containing red blood cells from the body. Maybe you're bleeding internally or externally. The symptoms that you have are going to depend on how much blood you've lost and how fast you lost it. Okay? Just think if I've been in a car accident and I've punctured my spleen or had some internal trauma, then I may lose a lot of blood in a short period of time. And so in that way, I'm probably going to have tachycardia, shortness of breath, weakness to the point that I probably go into shock. Versus if I have a small ulcer in my stomach, we'll say, and every now and then something I eat irritates that ulcer so that it bleeds just a tiny bit. Well, I may lose a little bit of blood over the course of so many days and then it stops. Those people are not going to lose a whole lot of blood probably in a short period of time, so their symptoms may just be some fatigue and a little bit of paleness to the skin and conjunctiva. Maybe I have lost red blood cells because my body is destroying them. I have hemolysis or hemolysis, however you want to say that. It can be due to a problem inside my vessel or outside my vessel. And hemolytic can be either genetic or they can be acquired. And we're going to talk about those on the next slide. A couple of inherited hemolytic anemias, maybe you have problems with the red cell membrane itself. This happens a lot when you have protein deficiencies. Maybe you have inherited what we call a hemoglobinopathy. This is where your sickle cell disease falls under this category, and then certain thalassemias that you probably read about in the past. We're going to talk about these more in just a second. Also, genetically, you can inherit enzyme defects, and the main one we're going to talk about is G6PD deficiency. We'll talk about again in just a minute. Your acquired hemolytic anemia is usually caused by certain drugs that you take. Prescription drugs can cause that. Certain chemicals or toxins or infections in the body. When I was pregnant with my child, I had what they call HELP syndrome, HELLP, and part of that, the H in that is hemolysis. And basically my body, because of the toxins in my body, had set up so much toxins that it caused my body to break down red blood cells, and my H and H was very low. And then people who have heart valves put in some are at risk for breaking down red blood cells. So let's talk about some of those individually. Beginning with hemoglobinopathies. Again, now these are all examples of hemolytic anemias or premature destruction of red blood cells. The first one is sickle cell disease. Pretty common, and I'm sure everybody's heard of this. It's an inherited autosomal recessive disorder. Affects African Americans, and these patients have an abnormal hemoglobin S. And that's important because it causes their red blood cells to turn into a sickle shape when they have a decrease in oxygen. And if you remember from the very first slide, we said that the reason that red blood cells were useful is because their shape allowed them to transport oxygen. With sickle cell, when these patients, the periods of a lack of oxygen or they are deoxygenated, basically some of their red blood cells will turn into the sickle shape. Well, their body sees those as abnormal cells and starts to break down or destroy those sickled cells, which causes them then to be anemic. Those sickled cells, in the meantime, can travel through the body, and they can't travel as well throughout the bloodstream because of their shape, and they'll actually get occluded in certain areas, usually in the joint spaces. And during a crisis, a sickle cell crisis, these patients will have very, very bad pain in certain areas wherever those sickled shaped red blood cells have accumulated. It can be in the abdomen, it can be in the chest, lower extremities, in the joints. Most of the time, patients who have crises will have those occlusions in the same places over and over again. So let's talk about what would cause somebody with sickle cell disease to have a crisis. Well, anything that would cause deoxygenation, exposure to cold weather, stress, physical exertion, certain infections, dehydration, acidosis, all of those things can cause deoxygenation of red blood cells and put a sickle cell patient at risk for having a crisis. So what do you want to tell these people? There's no cure. So basically, when they come in with a crisis, you want to give them oxygen because hopefully that's going to keep their cells from being sickle-shaped. Give them pain medicine, IV fluids. The key is education for these patients so that you try to avoid situations that cause deoxygenation or sickling episodes. Very important. If they feel that an infection is coming on, it's important that they seek treatment early. Cold weather, they need to wrap up, the scarf, the hat, everything, layers, all of those different things. Another type of hemoglobinopathy or hemolytic anemia are your thalassemias. Again, these are inherited, usually due to an absence or defect in the synthesis or the production of the alpha or beta chains of adult hemoglobin. Basically, it called have deficient hemoglobin production. And this is what we would classify as a hypochromic microcytic anemia. So this is where your MCV and MCHC value would be important to look at in determining if somebody had a thalassemia that was causing them to be anemic. There are two different types, alpha and beta thalassemia, and those are on the following slides. Alpha thalassemia is the most important clinical form of alpha thalassemia, is the formation of what we call hemoglobin H. You see this mostly in Asians. They have chronic anemia that requires them to get blood transfusions, specifically when they are having fevered illnesses, fevered infections, and then when they take certain medications. Beta thalassemias, these thalassemias are characterized, if you looked under the microscope, you would see what they call Heinz bodies. And those Heinz bodies actually impair the DNA synthesis and damage the red blood cell membrane. This is divided into thalassemia minor and major. We're not going to go into detail on that. Their long bones, the ribs, vertebrae are at risk for fracture. They do have new bone formation, which is usually in the face and makes them have a chipmunk appearance. And these patients usually have to have frequent transfusions. This is a little bit more, I hate to say worse, but it's a little bit more problematic than your alpha thalassemia. The last on your genetic hemolytic anemias would be G6PD deficiency. This is an enzyme deficiency that causes hemolytic anemia. It stands for glucose 6-phosphate dehydrogenase deficiency. Aren't you glad they They sum that up into G6PD, and if I put it on the test, it will say G6PD. But again, it's an inherited enzyme defect. And G6PD is an enzyme that keeps your red blood cells working properly during problematic times when you take certain drugs like aspirin or drugs that have the potential to cause problems. This particular enzyme keeps your red blood cells healthy and keeps them working. So, if you had a G6PD deficiency and you were exposed to one of those types of stressors that are listed on the slide, then your hemoglobin will form Heinz bodies, which will destroy your red blood cells. And anybody who's interested in knowing what fava beans are, they're something that you see a whole lot of in the Mediterranean, so you don't see that much here. And I've only seen a couple of kids that have G6PD deficiency. And mainly what you do is watch their diet, watch when they have infections, when they're sick, and watch the type of medications that they take. So we've talked about blood loss anemia. We talked about destruction anemia or hemolytic anemia. So now let's talk about when your body just doesn't produce enough. Big number one cause is iron deficiency anemia. This is when you have a low hemoglobin and low hematocrit due to a decrease in your iron or your iron stores, the ferritin level. Okay? Basically, maybe you're not eating enough iron in your diet, or maybe you've lost iron because you've bled a lot, or maybe you're having a period of time where you need more iron, such as with pregnancy. A lot of times it's because people are just not taking in enough iron in their diet. So think about this. If you have a low hemoglobin, then you have a low oxygen level, which can lead to the signs and symptoms on the next slide. Fatigue, pale, palpitations, feel like your heart's racing, shortness of breath, chest pain. A very common symptom of iron deficiency anemia is pica, and this is the compulsive eating of ice, dirt, or clay, and they really do it. They will eat dirt. More common for them to eat ice, but they will eat dirt and clay. A lot of the kidney patients that we have that are on dialysis, they have iron deficiency anemia just because they lose blood because of their chronic disease, and they will love to eat some dirt and clay, and it makes them constipated, which leads to a whole new different group of problems. Treatment: eat more iron. Maybe they need to take an iron replacement pill, ferrous sulfate, a vitamin, and then try to control any chronic blood loss, as in with my renal patients that I was just talking about. Some other nutritional anemias are characterized as megaloblastic because usually the red blood cells are very large. The MCV is greater than 100. These would be your macrocytic anemias, usually with vitamin B12 deficiency, folic acid deficiency. You have to have vitamin B12 and folate for DNA synthesis and red blood cell maturation. So if you don't have vitamin B12 and you don't have folic acid, then your red blood cells are not going to mature. And your DNA production is not going to be efficient. And you can read more about those in your book. I recommend that you read more about those in your book. Aplastic anemia is usually from, and actually is bone marrow depression. And if you have bone marrow depression, you're going to have a decrease in all three of your blood cells, not just red blood cells, but white blood cells and platelets. It can be sudden or it can be very slow onset. Usually the patients who have aplastic anemia are those who have cancer and have been on radiation and chemotherapy. because it not only kills the bad cancer cells, but it kills all the cells. So those patients will have aplastic anemia. Um, and then last is anemia of chronic disease. And it's not necessarily a megaloblastic anemia, but it's usually seen in patients who have a chronic problem such as kidney disease, AIDS, tuberculosis, lupus. And the reason they have anemia is because usually they have a large amount of macrophages in their body because of their disease, and it causes them to break down red blood. Y'all hang on because we're almost done. We're switching gears here and we're going to talk about a problem called polycythemia. This is where you have an abnormally high red blood cell mass. Your hematocrit is very high, usually greater than 50. Now, relative polycythemia is caused by a decrease in plasma without a decrease in red blood cell volume. What that means is you have a patient who, let's just say, comes in and they're dehydrated. Um, they have it appears that they have a large amount or a very high hematocrit, but it's basically because they're lacking fluid or they're lacking plasma because of their dehydration. It just makes their red blood cell volume appear larger. Basically what's happened is they have a decrease in plasma or the fluid level because of their dehydration. So it's relative. It's related to their dehydration. Okay. Absolute polycythemia is an actual increase in total red blood cell mass, and that can be either primary or secondary, and I want you to know the difference in this. Primary absolute polycythemia is also known as polycythemia vera. I can put it either with this, so you need to know both. And basically with this, you see an increase in all three of your red blood cells. Red blood cells, white blood cells, and platelets. And usually the blood volume and the thickness of the blood is increased as well. The way you treat this is by phlebotomy. You take out blood. These people actually, you have to remove enough blood and actually have to be at a blood count a little bit lower than what you would consider normal in order for their blood to circulate appropriately. Secondary absolute polycythemia is when there's some other cause causing an increase in red blood cell production. Normally, it's because somebody is hypoxic. They have a low oxygen level. And remember, anytime we say that you have a low oxygen level, your kidney is going to release erythropoietin and stimulate red blood cell production. The main way you treat this is to treat what's causing their hypoxia. If they have a chronic lung condition, maybe they need to be on oxygen. It's not that they're necessarily lacking red blood cells. Because they lack oxygen, their body compensates and says, oh, our oxygen level is low. We need to make more red blood cells. That's not necessarily true, but that's how the body responds. A couple of things on the neonate, the newborn. Hyperbilirubinemia is when the newborn breaks down lots of red blood cells. Their liver can't keep up with the breakdown. They increase in bilirubin, and it causes them to be jaundiced. A lot of times, there's a large amount of fatty acids in breast milk that can slow down the breakdown of bilirubin in the liver and cause them to be jaundiced. If you give them a bottle of formula, it'll probably correct itself. Not that I'm promoting that you give babies a bottle instead of breastfeed. That's not what I'm saying. But you see hyperbilirubinemia or jaundice in babies who are breastfed more than you do in those that are bottle fed. And it's just because their liver can't keep up with the way the body is breaking down red blood cells there in the very, very beginning. It will correct itself. And then hemolytic disease of the newborn caused by erythroblastosis fetalis. This is when an Rh negative mother has an Rh positive baby. In her first baby, after she has that Rh positive baby, she's going to do antibodies that causes her to break down her future newborn's red blood cells if she has more Rh positive infants. So basically, we check mothers in the very beginning to determine whether or not they're Rh negative or Rh positive. If they're Rh negative, then we give them RhoGAM 8 weeks of gestation and then right after delivery. Because if we don't, not in that first baby, but in their second baby, if they're Rh negative and they go on to have another baby, those antibodies are circulating in that mother and they're automatically going to go against that baby's red blood cells and break them down. So that is the end of red blood cells. So if you have any questions.